Hello and welcome back to Module 3, Symptom Management. Now we are going to wrap up our symptom management with general/other symptoms. So you're almost there, you're in the home stretch, hang on. You can do it. We are just going to talk about a last few. All of these obviously are complex, but we're going to do just a very brief and general overview so that you're aware of additional symptoms that patients experience at the end of life, just in case the prior videos weren't bad enough. So some of the things we're going to talk about in this video are fatigue, wounds, seizures, sleep disturbance, lipedema, and urgent syndromes. Fatigue is very, very prevalent in the end of life and with chronic conditions. So it's a symptom that needs to be managed at the diagnosis, continuing throughout palliative care, continuing throughout hospice care, and of course at the end of life, those few final days. It's very subjective, it's incredibly multidimensional, it's just this experience of exhaustion. It's been defined by patients as distressing, persistent. It's really just a subjective sense of physical, emotional, and even cognitive tiredness or exhaustion that is not proportionate to recent activity. So it's not like someone just ran a marathon and they're physically fatigued. It's prevalent in palliative care, commonly seen with cancer, heart failure, lung disease, HIV, MS, but it can have other causes as well. So some of the causes might be metabolic alterations. It could be possibly due to anemia, poor sleep, medications, deconditioning, depression, infection, organ failure, organ impairment. There's a lot of things that can cause it, but there are also behavioral lifestyle changes, and psychoeducational interventions are very important because different cognitive approaches can be helpful in dealing with fatigue, but of course there are also medications to manage fatigue. Wound care is also something that really needs to be managed at the end of life. A lot of patients may have aggressive or deep wounds, wounds that just won't heal, particularly homeless populations that don't have access to the care. Maybe certain cancers, if a patient has not had a lot of cancer treatment, perhaps they cannot afford it, then the cancer can be the tumors can migrate to the surface and cause open wounds. When I was in Thailand at the Buddhist temple that provided end of life care to patients, there were multiple tumors. There's one girl particularly that stood out to me. She was 26 years old and she had cervical cancer, but she had in either groin these large wounds, tumor masses that had come to the surface and just were red and raw and weeping and angry and painful. So when patients do have wounds, it's important to address these. Pressure injuries are another thing. We should always be on the lookout for preventing pressure ulcers, but patients who are cared for at home, perhaps their caregiver cannot reposition them as frequently as necessary, or perhaps the incontinence is causing excoriation to the skin. So there are different things to keep in mind. Assessments of the wound, of course, you're looking at characteristics. Is it causing pain? What are the psychosocial implications of this? And how is the caregiver able to manage the wound if the patient is being cared for at home? So when we talk about characteristics of wound, we want to talk about not only the wound itself and the base of the wound, but the peri-wound area, the drainage. Is there drainage? Is it significant? Is it purulent? Is it serosanguinous? Is there an odor? Is it possibly infected? There are different diagnostic evaluations that can be used as appropriate. So looking at transferrin and albumin levels, creatinine levels, hemoglobin, doing a CBC, doing wound cultures, these things may be appropriate when dealing with wounds. But remember, as always, anytime you're talking about lab or diagnostic studies at the end of life, you're asking yourself, will the findings alter the course of treatment to the patient's benefit to improve quality of life, or will this just be another form of promoting suffering? When treating wounds, frequent position changes, especially for pressure ulcers, is absolutely critical. Keeping the wound clean is necessary, providing clean dressings and frequent dressing changes is necessary, and especially providing analgesia, because it's important to manage the pain as much as we can for patients who have those wounds. Consultation with a wound specialist may be in order. It's always important to have that interdisciplinary team and to think beyond your standard interdisciplinary team providing that wound consultation. Prevention is key. So especially with pressure injuries, if they can be prevented, that is obviously ultimately the goal. Identifying the underlying cause of the wound, as with anything, is important. Is it a prior injury, amputation? Is it diabetes related, arterial insufficiency? Is there a lack of attention to turning the patient? Is there an inability of the caregiver to provide this standard of care to the patient? Are additional services needed? So that you should always ask yourself, will this patient's life be significantly better? Will there be increased quality of life if the wound is healed? Is it realistic if the wound is healed? So when you're talking about those goals, quality of life, is it realistic? How aggressive is it necessary for these wound cares? Because frequent dressing changes can be very, very painful. So while preventing infection, maybe the goal is to prevent infection. Maybe the goal isn't to heal the wound. Or the goal is to manage pain and prevent infection. Sometimes the goal is not going to be to heal the wound, and sometimes that is okay. I know it may be distressing to see a wound on a patient and know that aggressive efforts are not being applied to heal the wound, but the patient may die before the wound could have possibly healed to begin with. And so in that case, managing pain, preventing infection, managing odors are going to be your primary concern. You may see pressure injuries that occur 2 to 3 weeks before death. This is not uncommon and is typically occurring from organ death, because remember, the skin is the organ's largest organ system. So it may be unavoidable for every patient to remain free of pressure ulcers. Seizures can also occur at the end of life. Seizures are that sudden, abnormal, excessive electrical impulse in the brain that causes altered neurologic function. It can cause motor, autonomic behavior, and cognitive functional changes. And often the exact mechanism is unknown. So seizures can be caused by trauma, by brain injury, stroke, hemorrhage, HIV, metastatic brain cancer. They can be side effects of medications, of metabolic imbalances, drug toxicities, medication withdrawal. So there's a lot of different things that can cause seizures, and they can be very, very distressing to patients' family in particular. Seizures typically are preempted by an aura. So if the patient is cognizant, they may come to recognize an aura that comes before the seizure. And if that is the case, the seizure may be prevented. Sometimes medications can be administered and prevented. So seizures should always be considered a medical emergency. That is just the standard of care. We always consider seizures a medical emergency. 50% of seizures occur in people without a history of epilepsy. So that means that it could occur in absolutely anybody. So when you're doing your physical assessment, things that you're going to look at: orientation, speech fluency, things like motor function. You're going to do a sensory exam, oral exam, looking for trauma to the mouth or the tongue. So seizures, they're classified in different ways. They can be simple, complex, or generalized. And depending on the goals of care, you can consider doing a CBC, chemistry profile, coag study, TSH, blood cultures, blood gases, drug and alcohol screen, drug levels, a UA. There's different things you can consider. But remember, the ultimate question: burden-benefit ratio. Are we promoting quality of life, or are we prolonging suffering? And what will these exams tell us? Will it really inform the care in a way that will benefit the patient? There are various treatments for seizures. Obviously, you want to limit trauma, so decrease brain injury. And then there are anticonvulsant treatments, so things like phenytoin, phenobarbital, lorazepam, diazepam, Keppra. Those are all going to be pharmaceutical interventions. Now, this is one of the things that we are not going to do non-pharmacological intervention. We are not going to see if relaxation techniques are enough to prevent a seizure when a patient begins to experience an aura. The best non-pharm intervention is to prevent trauma. Otherwise, we are going to use anticonvulsants. Sleep disturbances they affect quality of life for the patient and the caregiver, and they are also prevalent within chronic conditions, especially as the patient nears the end of life. So yes, this is going to be one of the things that we really want to address so that we can increase quality of life for the patient and for the caregiver. It's very subjective, so a thorough assessment, asking those questions is important. Asking questions of the caregiver if the patient is unable or is able to answer the questions. Managing sleep disturbance, things like sleep hygiene, going to be things like avoiding stimulants close to bedtime, so no nicotine or caffeine, limiting daytime naps to either earlier in the day or shorter napping periods, keeping electronic devices such as TVs or phones or tablets out of the bedroom, keeping the bedroom cool and dark, limiting alcohol or large meals before bedtime. Those are all important things to consider. Now, if you do have someone with fatigue and sleep disturbance, typically they want to sleep all day. And that's going to increase the sleep disturbance or the insomnia. And so it's important to talk with the patient and ask them, when would you like to have the majority of your sleep? Do you want to sleep all day and be awake all night? If that's what they want, and that works with their caregiver, then they can have a reversed sleep cycle. But really, it's very difficult to promote sleep hygiene, particularly with daytime napping. That's just one of those tough things that the patient, it's all about the patient goals. You can provide education on sleep hygiene. If a patient insists on sleeping all day and is frustrated that they can't sleep at night, the best you can do is to explain ways that could help them sleep, and then go from there. Ultimately, it's their choice. Medications are also available as well. Melatonin is one of the more common pharmaceuticals prescribed. There can also be benzodiazepines or different medications for insomnia. Antidepressants can help with insomnia, atypical antipsychotics, antihistamines. There are multiple things that can help. But as you're addressing sleep disturbance, don't forget about the caregiver. Ask the caregiver, how are you sleeping? How many hours of sleep are you getting? How frequently is your sleep interrupted? And how fatigued are you? So it's the family unit. Lymphedema is a chronic and persistent. So it's a progressive swelling due to the failure of drainage within the lymphatic system. So this can occur either secondary to a disease or as a result from a surgery or radiation to the lymph system. So patients who are at risk for lymphedema are those who have had surgeries that involve removal of lymph nodes, particularly breast surgery with a node dissection, patients who have tumor burden to lymphatic chytes, and infection involving the lymph system or radiation to lymph nodes. So affected limbs can develop cellulitis because of the accumulation of the fluid. The lymphedema that is chronic, it's a result of inflammation, and it typically manifests as fibrosis and sclerosis. So symptoms, heaviness of the limb, discomfort, low range of motion, stasis ulcers, body image is big, quality of life is big. These are very common issues that occur with lymphedema. So as you're doing your physical exam and your assessment, you're inspecting the skin, particularly skin integrity. Is there any breaking? Is there any weeping? Does it look like there's an infection? Because with that cellulitis, sometimes that can turn to an infection. You're palpating for the pulses. as best you can. Depending on the lymphedema, you may not be able to palpate them due to the extent. You're looking at motor and sensory function, and you're also measuring the extremities to keep track of growth and improvement. As far as treatment is concerned, consultation with a lymphedema specialist is really going to be the #1 goal because they're familiar with skincare, with massage, manual lymph drainage, compression dressings, pneumatic compressions. It's a huge specialty, so going to a lymph specialist is going to be a big part of managing lymphedema in patients. Elevating the affected limb can be helpful in managing the symptoms. Educating the patient and family on monitoring skin integrity, to avoid heavy lifting, no hot tubs. Blood should not be drawn from the affected extremity. And then exercise should be increased, but only as tolerated. So the emphasis really is on meticulous skincare to prevent cellulitis. So the use of water-based moisturizers to prevent, is recommended to prevent the skin from drying out, but really it's that meticulous skincare and that consult and co-management with a lymph specialist. So some urgent syndromes, it's important to be familiar with the syndromes as they can frequently occur at the end of life. So really looking, assessment and management is crucial. Some of the syndromes you're going to see, superior vena cava obstruction. That could be from a tumor pressing on the superior vena cava. That's going to obstruct blood flow. Pleural effusion. That can occur with heart failure. The lungs are just inundated with that fluid. Hemoptysis can occur from treatments. It can occur from disease processes, spinal cord compression, particularly if there's a tumor. The patient can become paralyzed. They can lose bowel and bladder function, obvious loss of motor function. Depending on the level of spinal compression, it could also inhibit the respiratory effort, depending on how high the injury is. And then hypercalcemia is another one. So it could be a parathyroid or pituitary tumor. These are some of the things that you're going to look for. We're not going to spend a lot of time on them, but something just to be aware of in the back of your mind. So you made it through symptom management. This is a heavy one. You thought pain was bad. There's a lot of issues going on at the end of life, and now you can see, I hope, why it's so important to be aware of these different things, because the end of life is not, very rarely is it typically a soft, gentle guiding of someone into death. It is frequently characterized by these symptoms that increase suffering and are typically poorly managed. So it's important for you, the nurse, to be aware of these so that you can be an advocate for your patient. So multiple symptoms are common. It's not going to be just one. It's going to be multiple concurrently. It's important to coordinate that care with your interdisciplinary team. Remember your nutritionist, your wound specialist, your lymphedema specialist. All of those different specialists are really important in managing these symptoms. Pharmacological and non-pharmacological interventions are very helpful in the majority of the symptoms experienced by patients, with the exception of seizures. That's always going to be pharmaceutical intervention. And then providing patient and family support and teaching education, that empathetic listening, that presence of the nurse is also important. So we will put this all together in a case study. We will discuss things. We will talk about the complexities. And hopefully as we discuss this in class, you'll really be able to begin to comprehend these different things and put the pieces together so that it makes more sense.